Hello, my name is Ashley. I'm one of the second-year internal medicine residents at UNM. I'm presenting Yersinia pestis in a patient with a history of CLL. So our patient is a 64-year-old gentleman with past medical history of CLL in remission for 6 years who's presenting with a 3-day history of nausea, vomiting, diarrhea, and intermittent fevers. When the patient presented to us, his vitals were stable. Only remarkable vitals finding was that he was tachycardic with a heart rate of 107 on admission. As far as his labs were concerned, he had a white count up to 35,000 on admission. Physical exam was remarkable for a large, firm, tender, mobile, oval-shaped lymph node at the left inguinal fold that did not have any overlying skin changes on initial presentation. CT scan showed retroperitoneal adenopathy with numerous enlarged nodes, especially along the left periaortic region, and left inguinal lymphadenopathy. So the patient was treated for presumed viral gastroenteritis in the setting of a suspected CLL recurrence with IV ceftriaxone, fluid boluses, and antiemetics. The patient was totally stable 24 hours after and was tolerating a diet well and was subsequently discharged with close follow-up, including an outpatient interventional radiology appointment to have a radiology-guided biopsy of the left inguinal lymph node to confirm our suspicion for recurrence of CLL. His blood cultures were also negative when he was discharged. Subsequently, however, blood cultures were found to be growing gram-negative rods consistent with Yersinia pestis on speciation. So the patient was brought back to the hospital to receive gentamicin IV, and then he was subsequently discharged home with a 14-day course of PO Cipro, 750 milligrams BID, and had full recovery back to his baseline function and health. So interestingly, the patient actually did endorse what we suspect to be his exposure. When we brought him back to the hospital, he helps his wife clean out rat cages every couple of weeks, and we suspect that that is probably how he was exposed to Yersinia pestis. So the plague is a zoonotic infection transmitted by rodent fleas and the flea bites. It's really important to ask infected patients about possible exposures. It is a rare case of lymphadenopathy and fever, the plague is, but it has to be on the differential diagnosis for a patient who presents with these symptoms, especially in New Mexico, in order to prevent the high mortality associated with untreated Yersinia infection. As of August 2020, New Mexico has had 2 cases of the plague. One person succumbed to the disease, and the other person recovered. So just briefly going over the different types of plague. So there's 3 different types of plague. Bubonic plague creates buboes, which are tender, swollen lymph nodes. When the flea bites the person, and then they start to the bacteria multiply in the lymph node, creating the buboes. Typically, patients will have a sudden onset of fever, dizziness, and lymphadenopathy. And so our patient actually did have a buboes, and that was the lymphadenopathy present in the left inguinal area. Initially, he did not have any overlying skin changes, but when he came back for his treatment with gentamicin, he was found to have erythema over the area, which resolved with IV antibiotic. The second type of plague is pneumonic plague, and this is highly fatal if untreated, and it can be considered a form of bioterrorism. It primarily affects the lungs. Patients present with abrupt onset of fever, hemoptysis, dyspnea, or pleuritic chest pain, and it must be treated with IV antibiotics. You cannot give PO. The last type of plague is septicemic plague. This is characterized by hypotension and sepsis, usually without lymphadenopathy. The septicemic plague may be a progression of the bubonic plague as it is disseminating more throughout the body. Septicemic plague also requires IV antibiotics and can be highly fatal if untreated. So just in the area that we live and treat patients, it's very important to think about the plague in patients with lymphadenopathy and fever because over half of the plague cases in the United States occur in New Mexico. Thank you so much.